Hello.
Hello, sir.
Okay.
Good evening.
Good evening. Uh,
Good evening.
good evening.
Good evening, sir.
Good evening. I can hear you, Papa. Okay.
Sir, please, how are you doing?
Oh, by His grace. Oh, by His grace. Okay. Hmm. So we are going to look at the nervous what system. The nervous system. I think you have a your midterm starts. I think I've done some changes to it. I think it's open 6:30. So then up to I think I've extended it. So you have enough time to do it. So don't worry. If there's any issue, when the I'll know what to do. I've forgotten. I've been changing the time, so I've forgotten. So let's do what we are supposed to do today. Uh, let me try and see because I just did some changes to the time. So August. Okay, so I think it's open from 6:30 p.m. on Sunday to 8:30 a.m. on Monday. So now that's the duration. I don't want any problem with uh, someone saying that, oh, there was network problem here and there. Okay. Okay. So the nervous system. So you're going to look at the nervous system. The nervous system, what do you know about the nervous system? Maybe I can start from that end. What do you know about the nervous system? Any answer? Hello? Hello? Hello, I'm asking, Poku. I'm listening, Poku.
Hello, sir. So, with
Uh,
a little bit of idea I have concerning the nervous system, I would say the nervous system is primarily um has two constituents, to the best of my knowledge. That is the brain and then the spinal cord. And then
uh,
the nervous system basically helps in the controlling almost all the functions. I'm saying almost because we know, with the exception of the heart has its own conduction system. But aside that, the nervous system is responsible for almost everything, from cognitive function to movement and even to our endocrine function. The nervous system controls almost everything. So basically, I would say the two components that makes up the nervous system will be the brain and then the spinal cord. And probably you can take it from there.
okay. And that is, yeah, so you are spot on. Mm, you are spot on. Okay. So, if you look at the body, we mentioned about 11 systems or so. Then there are two systems, the endocrine system and the nervous system. We say that they control all the systems in the body. The nervous system by means of electrical impulses. Then the endocrine system by means of hormones. The nervous system is actually the master control and communication system of the body. It coordinates all activities that maintain life and homeostasis. It has three overlapping functions. There's a sensory input, and the sensory input deals with specialized cells that we call receptors that detects changes in the internal and external environment. The changes in the internal and external environment is what we refer to as stimuli or singular stimulus. So you have what we call temperature, pain, touch. Those are what? Stimuli. So you have sensory receptors that will detect these changes. Then these changes will be sent to the integration center, the processing and interpretation center by way of sensory neurons. So when a decision is made, then there's going to be a response. The response by means of motor neurons will go to muscles or glands. So that is what the nervous system does. The nervous system is divided into two main divisions. The central nervous system, which is made up of the brain and the spinal cord. Then the peripheral nervous system, anything outside the spinal cord and the brain. In fact, the central nervous system is where the integration occurs. That's the integration center. The sensory inputs and the sensory output will more or less will constitute a peripheral nervous system. Because you have here the peripheral nervous system. We'll talk about the cranial nerves, we talk about the spinal nerves, and we talk about the ganglia. The peripheral nervous system is divided into two main divisions. There's sensory division and motor division. There's a sensory division and there's a motor division. The sensory division or the afferent division can be grouped into two. There's somatic, there's what? There's visceral. Somatic in a sense that information from the body wall. From the body wall means the skin, the skeletal muscles, the bones, the joints. There will be sensory neurons that will take the information to the brain and spinal cord. Or information from what? The internal organs. Internal organs. So that one will be what? The visceral sensory. And that information will be sent to the brain. So if you look at from the body wall, touch, pain, pressure, vibration, proprioception, from the body wall, and you even have from the ear, then from the heart, eye, vision. Those are information from the body wall that will be sent by way of sensory neurons to the central nervous system. Then stretch, pain, temperature, chemical irritation, nausea, hunger. Then from the tongue, those, what do you call it? Taste receptors, the tongue, and smell. Those are visceral sensory information that will be taken to the central nervous system by means of sensory neurons. So the information can be coming from the body wall, or it can be coming from the internal organs. So when it gets to the central nervous system, then the information will be what? Processed. Then the interpretation will be by means of what? Motor neurons. So the motor division, we also have somatic and visceral. Somatic means that the information is going to the skeletal muscles. And visceral means that the information is going to the smooth muscles, the cardiac muscles, and the glands. The visceral motor division of the peripheral nervous system is what we call the autonomic nervous system. It's what we call the autonomic nervous system. Now you can see that the autonomic nervous system, you see this is the efferent division, somatic nervous system, it goes to skeletal muscles. Then there's a visceral motor division. And that one goes to the smooth muscles, the cardiac muscles. So I said as a visceral motor division, that's what we call the autonomic nervous system. So this one is the voluntary because it's going to skeletal muscles, and this one is the involuntary. And the autonomic nervous system is divided into sympathetic and parasympathetic. There's a third division that is able to work independent of the central nervous system. That's the enteric nervous system. And with this one we're looking at the digestive tract, where we mention the enteric plexus and the submucosal plexus. So this is an overview of the nervous system. Remember, the peripheral nervous system has sensory division and motor division. Each division, there's a sensory and there's what? There's a visceral. Okay. So there's afferent is sending information. The efferent is taking information after the brain and the spinal cord have processed the information. So it either go to the skeletal, somatic, or it go to the smooth muscle, cardiac muscles, or the glands. And that will be the autonomic or the involuntary nervous system. Okay. Now let's look at the brain and the spinal cord. And by the brain and the spinal cord, we are going to go straight and talk about something very important. I'm actually going to use, I have the information in my notes all right, but I want to open the book, the recommended book, so that it will not be as if what I'm talking about. In fact, the other class, when I said it, I thought maybe they didn't need it. But when I just checked the notes, I saw that it was in there. Okay, so now you can see your slide very nicely. So it is actually here, this part that I want you to see. This is the part that I want you to see. So very early in development, in the third week of development, there's a process that occurs that we call gastrulation, where the three germ layers, the ectoderm, mesoderm, and endoderm, these three germ layers develop to become the tissues and organs of the body. So there's a process. The first system to develop is the central nervous system. And it began very early, around the late third week or around early fourth week. There's a process that forms that we call neuration, the formation of the neural tube. So this one here is a neural tube. This one here is what we call a neural tube. So you can see there's a formation here that we call the neural plates, where there's a neural groove, where there's a neural fold. Then you see that the fold eventually close here, this side close. And as they close, there are some cells that will be pinched off that we call the neural crest cells. Now, when they are closing, they close from the midline, and they then caudally, then cranially, then caudally. So the closing starts from here. Now, there's a particular time for this side to close. There's a particular time that this side will close. We call this one the anterior what? Neuropore. The anterior neuropore. It closes at a particular what time. It closes at a it closes at a particular time. That is around day 25. That is when it is supposed to what? To close. Day 25. Okay. By day 25, it should what? It should close. So this one is showing the formation. Neural plate, neural groove. Then you definitely will have a neural what? Tube. Then this is when it is closing. It closes cranially. It closes what? Caudally. Now, this opening here are the neuropore. So there is anterior neuropore and there's posterior neuropore. The anterior neuropore is supposed to close by day 25. If it fails to close, then you have what we call ancephaly, which is an open neural tube defect. Failure of the rostra or anterior neuropore to close. So you see that there's no forebrain and there's open what? Cavarium. Such people will have a high alpha fetal what? Protein in the maternal what? Serum. Then when the posterior neuropore also fails to close, then you have this condition that we call the spinal what? Bifida. So one way of reducing the chance of getting these neural tube defects is for women to take what? Folic acid when they want to get pregnant and during the second trimester of our pregnancy. They can reduce this effect by 50 to 70 what? Percent. Okay. Now, the neural crystals, these cells that are formed in the formation of the neural tube. In fact, they are the ones that goes to form the Schwann cells. If you remember the Schwann cells, they form the Schwann cells. They are the ones that migrate to form the submucosal plexus and the myenteric plexus. So remember when we said that when they fail to migrate to form those ones, there's this condition that we call the what? The Hirschsprung what? Disease. So there are so many things that these neural crystals they form. So that is by the way. Hello. I'm listening. Hello.
The location of the neural tube, where it is located, please can you go
raise your hand before you talk?
No, the neural tube becomes the neural tube is what is going to be from the brain and the spinal cord.
Okay.
Please, the neural tube, the neural tube. Hello, the neural tube. You know that there is a space here. The cavity here is going to form the ventricles. It's going to form the ventricles in the brain and the spine and the central canal, the spinal cord. Then the rostral part of it are going to form the brain. Then the caudal part is going to form the spinal cord, the final cord. So this neural tube that is formed is what's going to develop to become the brain and the spinal cord. And the cavity that you have there is going to form the cavity in the brain, the ventricle, the cavity in the spinal cord, what we call the central canal. So very early in the 4th week development, there are 3 from the, as I said, neural tube, the rostral part of the neural tube. There's a caudal part of the neural tube. The caudal part of the neural tube is going to form the spinal cord. From the rostral part of the or the cephalic part of the neural tube, you're going to have these 3 primary vesicles: the prosencephalon, the mesencephalon, the hyencephalon. Around week 5, the prosencephalon will give rise to the telencephalon, and the diencephalon. The mesencephalon remains. Then the rhodencephalon, which we call the hindbrain, will give rise to the metencephalon and the malencephalon. So these 5 vesicles in the adult structure, you have the telencephalon becoming the cerebral hemispheres, the diencephalon becoming the thalamus and the hypothalamus and the epithalamus. Then, of course, the mesencephalon will remain as the mesencephalon, the midbrain. Then the metencephalon will become the pons and the cerebellum. Then the malencephalon will become the medulla oblongata. So developmentally, what I mean is that the medulla oblongata developed from this secondary vesicle that we call the malencephalon, while the pons and the cerebellum develops from the metencephalon. Then the midbrain, of course, developed from the mesencephalon. The thalamus, hypothalamus developed from the diencephalon. Now, remember this, I told you that the cavity that you have, the cavity in the brain is the ventricles. So you realize that in the telencephalon, in the cerebral hemisphere, you have what we call the lateral ventricles. In the diencephalon, we have what we call the third ventricle. In the midbrain, we have what we call the cerebral aqueducts. Then behind the pons and the medulla and in front of the cerebellum, we have the fourth ventricle. The fourth ventricle. Okay. So that is that. So you realize that the main parts of the brain are the cerebrum. So this is the cerebrum. This is the cerebrum. Then this is the diencephalon. The diencephalon, we have the thalamus. Then there is the hypothalamus. There is this area here that we call epithalamus. In fact, some even talk about methalamus and subthalamus, but I'm not going to talk about those ones. So the epithalamus, the important structure that we'll learn there is the pineal gland. Then there is the cerebellum from the metencephalon. And there is the pons from the metencephalon. This is the midbrain from the mesencephalon. And this is the medulla oblongata from the malencephalon. The midbrain, the pons, and the medulla oblongata will constitute the brain stem. So the main part of brain is the cerebrum, the diencephalon, where you talk about the thalamus, hypothalamus, the cerebellum, and the brain stem. The midbrain, the pons, and the medulla oblongata. You should be able to identify each of these any time of the day. So if you look at this one here, this is a cerebrum. This is a cerebellum. This is where you have the diencephalon. This is the brainstem, the midbrain, the pons, the medulla oblongata. At the foramen magnum, it will continue as a spinal cord. So once again, the whole of this here is the cerebrum. This is the cerebellum. Then this is the brainstem, the midbrain, the pons, and the medulla oblongata. Now, if you want to see the diencephalon, it has to be deep. It has to be deep. So once again, if you look at this view here, this is the cerebrum. This is the diencephalon. This is the thalamus. This is the hypothalamus. This is the midbrain. This is the pons. This is the medulla oblongata. And this one is the cerebellum. So please, those are the parts of the brain. So I'm going to look at all the parts of the brain. Those who are making noise, just mute yourself. Okay. So before we look at the
Sir, please
before we look at
kindly
the parts
unmute.
of the
Unmute.
before we talk what do you call it? We look at the brain. Let's look at the protection of the brain. So we said that the brain is and the spinal cord, they are protected by the bone, by meninges, and by the cerebrospinal fluid. We already know the bones. The brain is protected by the cranium, which are 8 bones. The spinal cord is protected by the vertebral column, the vertebrae, which we know to be 26 in an adult. So we are not going to go into that because it's already done the skeletal system. So we are rather going to talk about the meninges, which are connective tissue membrane. From outside to inside, we have the dura mater, the arachnoid mater, and the pia mater, the tough matter. Now, this is the dura mater. This is the dura mater. So this side that you are seeing is the dura mater. Now, what you have it covering here is the arachnoid mater. So this one here, this transparent thing that you are seeing here is the arachnoid mater. The pia mater is firmly attached to and follows the convolutions and depressions of the brain. So it's not something that you can what do you call it, peel and show. So it's important that you know these things. Now, the dura mater has 2 layers. There's an outer layer which you call the endostia. Then there's an inner layer, the meningia. Now, the outer layer here and the inner layer, at this point that you are seeing it, you can't separate the two. They are fused. But here they are not fused. There's a gap. Here they are not fused. There's a gap. So that is where you have the dura venous sinuses. The veins of the brain, they drain into these dura venous sinuses. And the dura venous sinuses lies between the meningeal and endostia layer of the dura mater. The meningeal layer, the meningeal folds on itself to compartmentalize the brain. So you have the meningeal fold separating the 2 cerebral hemispheres. We call it the falx cerebri. We have that was separating the 2 cerebellar hemispheres, the falx cerebelli. Then we have this one here separating the cerebellum from the occipital lobe. We call it the tentorium cerebelli. The tentorium cerebelli. The tentorium cerebelli. Okay. Call it the tentorium cerebelli. There's another one that I can show, but okay, let me just try and see whether I can. But so those are the ones that that one that you should know. That one that you should know. What I wanted to add was let me see what I can. Sometimes I try to delete a lot of things so that if I don't do that, the slides becomes what? Plenty. The slides become what? Plenty. The slides become what? Plenty. So you are actually, which one is even better? I say more. Which one is even better? So you have something like this. So yeah, so this is how it is. So if you can actually see it that way, if you can see it, that's nice. So this is a fast cerebri. This is a fast cerebri. So it means that the left cerebral hemisphere here, the right cerebral hemisphere here. Then the cerebellum will be lying here. Then this is the tentorium cerebellae. Separating the occipital lobe will be here. So this tentorium cerebellum, the one that they are calling A, will separate the occipital lobe from the cerebellum. Then this notch that you are seeing here is the tentorial notch for the brain stem. So if you look at the brain this way, the frontal lobe will be located here in the anterior cranial fossa. The frontal lobe will be located here. The temporal lobe will be located here. Then the cerebellum will be here. Then you have the tentorium cerebellae. Then the occipital lobe will be here. Then the notch here, that's where the brain stem. So the midbrain will be here. The pons, then the medulla oblongata, which will continue as the spinal cord. So just remember that there's a connective tissue membrane, the dura mater, the arachnoid mater, and the pia mater. Now, I also want to once again use another image here to show you. And this image here, I want to zoom it so that you can see it very well. Now, I will use it to explain a lot of things, so just pay attention. Now, so here you can see the dura mater. This is a dura mater. So here they are showing us the endosteal layer. One, they're showing you to the meningeal layer. And at this point, you see that they are firmly attached. Then this is where they separate. And where they separate, I said that we have the dural venous sinuses. So the veins of the brain, they drain into the dural venous sinuses. Now, this one here is the arachnoid mater. Then this one here is the pia mater. So you see that the pia mater is fairly attached to the brain tissue. Arachnoid, because look at this mesh square that they form. You know, our class of arachnida is where you can find the spider. Okay. There are important spaces too that I want you to note. There are important spaces that I want you to know. Between the bone and the dura mater, there is a potential space. Please, it's not an actual space. There's a potential space. There is a potential space. So if you look at this one here, this is the endosteal. This is the meningeal. Then in between, we have the dural venous sinuses. So this is arachnoid mater. And this is a pia mater. This is a pia mater. So above the dura, so we call the epidural space. Epidural space. Epidural space. Then below the dura, subdural space. We have the subdural space. Then below the arachnoid mater, that will be the subarachnoid space. That will be the subarachnoid space. So those spaces are very important. Those spaces are very important. Now, the blood supply, I believe that you learned something about the theon. Do you remember the theon? Do you remember the theon? Okay, let me show you something. There's an artery that we call the middle meningeal what? Meningeal what? Artery. Hey. Middle meningeal what? Artery. Hey, what is happening? I'm typing the thing in middle. Hey, I'm hoping that what is happening? So I'm typing middle. Hey, I think when I explain it, you understand it. So I'm going to continue like that. I don't know why it's not responding the way I want. Okay. So the point that I'm trying to explain is over here. So I'm trying to explain here. The artery that supply the dura, you call the middle meningeal artery. So just above the 3 to 4 centimeters above the zygomatic arch, the bone there is thin. So when there's a trauma there, it can tear the middle meningeal artery, and blood will collect at the epidural space between the bone and the dura mater. So the extradural, the epidural space is a potential space. It's the site of epidural hemorrhage from rupture of the middle meningeal artery. Then if you look at this one here, this is a dura mater and this is arachnoid mater. So the space here is the subdural space, and you can see some bridging veins. So when there is a rupture of the bridging veins, then you have subdural hemorrhage. Subdural hemorrhage. Here is a vein, so the blood will not. It takes time, but here it's an emergency. Okay, then the most important space, this one is an actual space between the arachnoid mater and the pia mater. That's the subarachnoid space. The subarachnoid space contains cerebrospinal fluid. You can even have subarachnoid hemorrhage. Okay. So this one here is MRI showing epidural hematoma. This one is showing the subdural hematoma. Okay. That is that. Ben, you can ask your question.
Thank you, sir. So I just wanted to seek for clarification on what you mean when you make mention of an actual space. Because you have mentioned that a subdural space is an actual space, but there was this one space that you were actually making mention of that you stated not so firmly that this is not an actual space, might be not. So I just wanted to know why we are saying some are actual spaces and some not so much.
Because if you look at here, this one here, this is the bone, and this is the dura mater. So here you'll find maybe some connective tissues were there. So that's what I mean by it's not an actual space. You see, it's just like saying that the peritoneal cavity is not an actual is a potential space. In other words, we are saying potential in the sense that you can have fluid collecting there. So here, unless there's the artery, they get torn. Is when the artery get torn, then of course the blood will collect in this space. Then it becomes an actual heart space. But if you look at your subarachnoid space, the subarachnoid space, that is where the CSF is. So this is a subarachnoid. This is the arachnoid meter and the pia meter. Here, if I'm to zoom it, this is the arachnoid meter and this is the pia meter. So this is the subarachnoid space. So here is an actual space where you have cerebrospinal fluid flowing. But the epidural space, you see, like myself and you, well, we are healthy. It's only some fat and those connective tissue that are there. Of course, fat and those connective tissue. But then when we have blood begins, there is a tear of the arteries. Then of course you have blood collecting there, and that one will put pressure on the brain. So that is why we are saying that those ones are not spaces where fluid collects. Fluid collects when there is what? A problem. When there's a rupture of an artery, or when there's a rupture of what? A vein. Then that space becomes what? Is then that you have is blood filling that space, and then that space will cause a problem because it's going to exert pressure on the brain tissue. Okay. This one, this one is just for you to know that the veins of the scalp, they communicate with the dural venous sinuses through what we call emissary veins. So the infection of the scalp can actually trickle to the to the dural venous sinuses. Okay, so now that we've touched on the meninges, we can look at the CSF. So the CSF within the ventricle, we are going to look at the ventricles, then we talk about the CSF. So the ventricles, we said that the cavities in the brain are called ventricles. The cavities in the brain are called ventricles. The cavities in the brain are called ventricles. And the ventricles, they contain what we call choroid plexus. They contain what we call choroid plexus. So the choroid plexus will produce the CSF. So the CSF is actually a filtrate of the blood. The CSF is a filtrate of the blood. So normal CSF is a clear film isotonic with serum. So this is a CSF composition of CSF, and this is a composition of the blood serum. So just a filtrate. Okay. Now, and we are saying that there is a choroid plexus within the ventricles. And what are the ventricles? Within the telencephalon, there is a lateral ventricle. Within the diencephalon, there is a third ventricle. Behind the pons and the medulla, there is a fourth ventricle. So those are the ventricles. Now, between the lateral ventricle and the third ventricle, there is an opening that we call the interventricular foramen, or the foramen of Monroe. That is someone's name. Then between the third ventricle and the fourth ventricle, there is the cerebral aqueduct, which passes through the midbrain. So the CSF, the choroid plexus, all the ventricles will have choroid plexus. So the choroid plexus that will produce CSF in the lateral ventricle, they will flow through the interventricular foramen into the third ventricle. Then from the third ventricle, they flow through the cerebral aqueduct into the fourth ventricle. Into the fourth ventricle. Then at the fourth ventricle, we have openings. There are two lateral openings. The lateral aperture, or the foramen of Luska. And there's one median aperture, the foramen of Magindi. So the CSF will leave the fourth ventricle into the subarachnoid space. Then the CSF we see circulating in the subarachnoid space. Now I want to show you something here. Now in this image here, we can identify this thing here. This is as the arachnoid meter. Can you see this arachnoid meter? There is it protrudes into the dural venous sinus. We call them the arachnoid villi or the arachnoid granulation. The arachnoid granulation. So the CSF that is flowing through the subarachnoid space, when it reaches here, depending on the pressure, the CSF will drain into the dural venous sinuses. So every day, about 400 to 500 milliliter of CSF are produced. And as I said, as the CSF are produced, they should be They should be drained. As they are produced, they should be drained. You can see CSF in the ventricular pathway, and you also find CSF in the subarachnoid space. Now there is a condition that we call hydrocephalus. Hydrocephalus. And how does hydrocephalus come about? Hydrocephalus is when you have excess cerebrospinal fluid. So either there's an overproduction of the CSF, there's an obstruction in the pathway of the CSF, or there is a problem with its reabsorption into the venous system. Remember, once you get here to eventually leave the scar through what we call the internal jugular vein, to the internal jugular vein. So hydrocephalus is excess CSF, and I've explained to you why we can have the excess CSF. There are several types of hydrocephalus, but we are not going to look at all those many types of hydrocephalus. We are going to talk about the two that we all know. There's one that we call the communicating hydrocephalus and the non-communicating hydrocephalus. And let me explain what we mean by communicating and non-communicating. Now, you see, I've explained that hydrocephalus will result when there's a problem with reabsorption into the venous sinus, when there's obstruction in the subarachnoid space, or when there's an obstruction in the ventricular system. If the CSF is able to flow from the lateral ventricle through to the third ventricle, then to the fourth ventricle, then, and you rather have obstruction in the subarachnoid space or a problem of reabsorption in the venous, then we call it communicating hydrocephalus. Communicating hydrocephalus. In other words, the ventricular system, they're able to communicate. So that one, there's no problem there, but the problem is whether it's reabsorption or obstruction in the subarachnoid space. Then we have non-communicating. Non-communicating means the ventricles, they don't communicate. That means there's an obstruction there. So non-communicating hydrocephalus is what we call obstructive what? Hydrocephalus, and it's very common in what? In children. So you can have, let's say, if there is a narrowing compression at the foramen of Moreau, then the CSF is not able to flow into the third ventricle. Or let's say there's a tumor affecting the midbrain, then the CSF is not able to flow from the cerebral aqueduct to the fourth ventricle. The CSF is going to accumulate in the third ventricle, then in the lateral ventricle. That is what we are calling non-communicating or obstructive what? Hydrocephalus. So here you can see from the MRI here, you can see the pons, you can see the medulla. So this is a fourth ventricle. This is a midbrain, so we can see the cerebral aqueducts. And this is where the third ventricle is. Okay. Kwabna, you can ask your question. Kwabna.
Okay,
Oh,
sir.
Kwabna, your hand is out. Yes,
Yeah,
it's up.
I wasn't able to read. I just got access to Thank you. I got the non-communicating hydrocephalus, where there will be a tumor that will block the
Any
cerebrospinal
obstruction in the
fluid.
ventricular pathway.
Okay, so I want you to come again on the communicating. I didn't get that quite well.
So you see that when they are using they are using the word communicating and non-communicating. And when they are saying communicating, they are saying that like the ventricles, they communicate. Like CSF from the lateral goes to the third, from the third it goes to what? To the fourth. So when there's a communication among the ventricles, and so it means that one, there's no problem there. But the problem is actually in the subarachnoid space or in the 8th reabsorption to the venous sinuses. So we call that one communicating what? Hydrocephalus. That means the problem is not where they are produced and when they flow from one point to another. But when they say non-communicating, then it means that the ventricles, there's an obstruction in the ventricular pathway. So that's why we are saying that it's non-communicating. That's why we are saying non-communicating. I should rather show you this diagram too, because this diagram is very important. In this diagram, there is something that you can see here. So we have two hemispheres. So you realize that I told you that the telencephalon is where we have the lateral ventricle. So the lateral ventricle has horns. So there's a frontal horns or the anterior horn. You see, it's within the frontal lobe. Then the body is in the parietal lobe. Then there's a posterior horn in the occipital lobe. Then there's a temporal horn in the temporal lobe. Okay, so the temporal horn can also be called the inferior horn. I'm showing you that way because sometimes when you look at it in let's say the ventricles corona section MRI, you should still be able to see the ventricles. You should still be able to see the ventricles. You should still be able to see the ventricles. So let me actually even use this one first. This one is showing them. So if you look at this one here, let me try and explain something here. You see that I'm not talking about that one, but you can see this thing that you are seeing here is called the septum pellucidum. So the ventricle here, this is the lateral one. This is a lateral ventricle. This one too is the lateral heart ventricle. But remember, I was telling you that, you see, this is the occipital lobe. This is the frontal heart lobe. So this is a posterior horn of the lateral ventricle. And this one here is the lateral heart. The, what do you call that? I said this is the occipital horn. That means the posterior. Then this is with the frontal horn of the lateral ventricle, or the anterior heart horn. You see, this is the thalamus. This is the thalamus. In between the thalamus is here. In between the thalamus, there is a third heart ventricle. So this is a third ventricle. So the CSF will flow from here, the lateral ventricle, through this side here, the interventricular foramen, then gets into the third heart ventricle. So once you see the thalamus, you should be able to see the third ventricle. So that's why I was making the point that once you know the region of the brain, you'll be okay. You'll be okay. So that is about the CSF. So definitely this one here will be the fourth ventricle. Here they are showing the choroid plexus. They are showing the choroid plexus. So you see, this is the thalamus. So you see that they are showing us this one to be the third ventricle. Then this one here is the lateral ventricle. Okay. So when there is hydrocephalus, they definitely will show. When there is hydrocephalus, you definitely will see in the, Okay. Now, when you have hydrocephalus, the fluid can be drained. The fluid can be drained. They will connect a shunt from the ventricle to the peritoneum, what they call ventriculoperitoneal shunts. If you look at this one here, you can see a hydrocephalus. Look at here. The space, you can see that you have a lot of fluid here. You have a lot of fluid. But as I said, there are several types of hydrocephalus. So there's one that we call normal pressure hydrocephalus. It's not all the hydrocephalus that leads to increase in intracranial pressure. But I think knowing the communicating and the non-communicating one is more than enough. It's more than what? Enough. Okay. It's more than enough. So at least this is a hydrocephalus. Now, with a child, because the brain, the bones are not fully ossified, you see, it can stretch. It can stretch. But if it happens to you and I, we'll die because our cranial bones are fully ossified. So they can accommodate the expanding the fluid accumulation. So rather, there's going to be pressure. There's going to be pressure on the brain tissues, and it can die. Because the 8 cranial bones are connected by sutures, and the sutures are not fully ossified. So we are saying that it can cause the scar to actually stretch. That's why you are seeing the head this way. Depending on the age, when you drain the CSF, everything can return to normal. That one depends on the age. So this is the shunts and the ventriculoperitoneal shunts. I think when we did the abdomen digestive system, I said something about the peritoneum being used not only to drain excess CSF, but also used as a dialysis. Now with that one, Okay, let me also say something here. I taught the other class, so let me move straight so that I can also talk about it with respect to you. Okay, so there's a point that I want you to note. The spinal cord too is protected by meninges. So the cranial dura mater continue at the spinal dura mater, and that one ends here. It ends as S2. So this is where the dura mater, the spinal dura mater is ended as S2. This is where the spinal cord is ending. The spinal cord is ending in adult as what? As L1. So anywhere here, you can take what? CS what? You can take CSF. The subarachnoid spaces, where there are places where it's dilated or it's enlarged, we call those ones the cisterns. So when you do lumbar, what do you call it? Lumbar cistern. So there's a lumbar cistern here. So here the CSF, you can drain the CSF here. Remember, I told you, I remember when we were looking at the female reproductive system, and I made mention of these things. So this one here is what? Spinal what? Lumbar what? Spinal what? Puncture. So this one is the epidural space. I remember when I was talking about, I said that you can release the anesthesia into this space here, the lumbar what cisterns. Then I said that when you do that, you block all the nerves. So even between L3 and L4, you block all the nerves what below. But sometimes the anesthetic agent can also be released just in the epidural what space, as you are seeing here. So you see here, the lumbar injection is in the epidural. It's in the epidural. That means before the dural what mater. But this one here, we are in the space between the arachnoid mater and the pia what mater. Now, in the spinal cord, there's another interesting thing that happens in the spinal cord. In the spinal cord, look at here, look at the pia mater. The pia mater form two important structures. You see that the pia mater is forming this structure here that we call the denticulate ligaments. That will kind of hold the spinal cord to the dura mater laterally. Then the same pia mater will also form this thing here. Have you seen this thing here? They call it the what? The phenum what? Terminale. It extends all the way, go through the dural sac. This one is better. So this one is the phenum terminale. So this one is an extension of the pia mater. It goes all the way, pass to the dural sac, then continue all the way and attach to the causes. So that you have the spinal cord secured inferiorly, secured what? Laterally. So it's not as if it's floating like that. No, there's actually a support from these what do you call it? Pia structures. Pia structures. Okay, so that is just by the way. Hey, so let me use the remaining time to look at the structures one after the other. So with that one done, okay, so this one is talking about a lumbar puncture, where the CSF is sampled from the subarachnoid space, usually between L3 and L4, because the spinal cord is ending at L1, or between L4 and L5. You see, when a person flexes this way, and you're able to palpate the iliac crest, the iliac crest is at the level of L4. So once you release the anesthetic agent below L4, you know that you are safe. But of course, the person will have to flex. Okay. So the parts of the brain, let's start with the diencephalon. So we are going to talk about the thalamus and the hypothalamus. Then we also add the pineal gland. Osei, you can talk. Osei.
Hello, sir. Please.
Oh, that one is a mistake. Your hand that is up.
Hello.
Yes, I can hear you.
Okay. Please, I want to ask a question.
Yes, you can ask.
Concerning with the spinal,
Concerning what?
the CSF. Assuming anesthetic is giving an anesthetic agent, we know that normally it is being injected between the L3 and L4. But we said the CSF ends at the L1. So
the spinal cord ends at L1 in
the
adults.
spinal cord ends at the L1. So in a situation where you tap and you cannot get any fluid, can you go up to, let's say, L2 to tap from there?
Oh no, that one, please. That's why I said that if you look at that space, the space is big. The space is big. That's why we call it a system. So look at here, the space here. So if it's ending at the lower border of, so someone would say L1, L2. So if it's ending here, this side here, this space is big. Is big. It's big. You can get the CSF from there. But the problem is that you see, you need, how do you know the exact part that you are puncturing? So that's why we are saying that, how do you know you are L1? Why do you know which side is your L2? So if you look at this image here, the image is even nicer. So this image is telling us that when a person flexes this way, this is the iliac crest. So once you're able to palpate the iliac crest, then you see that you are at the level of what? This side will be at the level of what? L4. So at L4, if you go above it, you are still safe. And if you go below it, you are still what? Safe. It's just that you don't want a situation where you will hit the spinal cord. If you hit the spinal cord, then that one is a disaster. Now, you see that I told that there's a phenum terminale here. So there's a phenum terminale here. You also have rootlets of the sacral and coccygeal roots. They are also there. The so-called caudal equina. They are there. But because they are bathed in the fluid, there's no way this one is in the fluid and you have a needle. There's no way it's going to hit any of them. It's not going to hit any of them because they are bathed in the fluids. It's not going to hit any of them. So yes, you can go above L4. You can go between L2 and L3. The whole idea is that don't get to a place where you end up damaging the spinal cord. That is all. You don't want to, So is the landmark that you can use. You can even get the CSF from here, but this one is not usually done. I told you that the systems, large or dilated subarachnoid space are called systems. Between the medulla and the cerebellum, that space is big. So that's why they are also taking CSF from there. We call the cerebellum, the cisterna magna. Okay. So, yes, that's a short answer. Just don't get close to the spinal cord. That is all. Don't get close to the spinal cord.
Okay, thank you.
Now, the thalamus. The thalamus is a relay station. The thalamus is a relay station. So that's the first thing I want to know. It's a relay station. I've not done the cerebrum there, but then watch this side here. This is the thalamus. The current that they are showing us, they are trying to tell us that the thalamus has several nuclei. The thalamus has several nuclei. Now, I want to start with this one here that you can see. You see, there's a nuclei here, lateral geniculate what? Body, or the lateral geniculate what? Nucleus. Look at here. If you look at the cerebrum, you see they made it here. So when you say a relay station, motor information will pass to the thalamus. Sensory information will pass to what? The thalamus. So, so you have something like that here. Information from here will pass the thalamus. This is the thalamus, is here. Information also coming down will also pass to what? The thalamus. So all sensory information will pass to the thalamus, except the sense of smell. Except the sense of smell. The olfactory air will be passing here. So then you have a lot of motor information while passing there. So that point is very important. So the thalamus is just like your school reception or whatever you work. You have to see the reception, then they tell you where to go. So I like you see, if you look at Garden City, if you want the nursing department, you have to go to see the receptionist. Then they will tell you where to go. If you want to go to the medical department, the same way, you have to go to the receptionist. Then they will tell you where to go. So most of the information, the sensory information and the motor information, they have to sign up with the nuclei of the hypothalamus. Then the hypothalamus will project it to the specific area on the cerebral cortex. So that is why you have the colors that you are seeing this way. So here, the lateral geniculate body is a relay station for vision. So you see this one. This is the what do you call it? The primary visual cortex. The primary visual cortex. The primary visual cortex. So you see this one here. This is the optic nerve. This is the optic tract. This optic tract will sign up with the lateral geniculate body. The lateral geniculate body will pass through the thalamus. Then from the thalamus, will pass through that. So here, this is it here. It will pass through the thalamus. Then the thalamus will project it to the primary visual cortex. So that is what I mean by being a relay station. Now, if I use another example, look at here. This area here, this is a parietal lobe. This side here is a primary visual, primary somatosensory cortex. All sensory information, this is where they all land in the cerebrum. But before they get here, they have to sign up with this nuclei. So, for example, pain, temperature, sensation. Someone touches you, there's a pain, there's pressure, sensation. What we are saying is that those sensations, they are coming to this area, the postcentral gyrus. They are coming here. But then they will sign up with the nuclei VPL in the thalamus. Then it will be projected to this area. So that is what the thalamus does. Everything passes there, then it relay it to a specific region. The only sensory information that doesn't pass to the thalamus is the sense of smell. So what it means is that if pain, temperature, sensation, there's a damage to this nucleus of the thalamus, then there's a problem. It cannot get this to this part of the cerebral cortex. So that is that. Then look at here, the medial geniculate body. Look at where it's going. That one will be coming to this side there. This one here is coming to this side. So they all have specific areas where the information will go. Now, another important thing in the diencephalon is the epithalamus. The most important structure there is the pineal gland. In fact, the epithalamus is not the same as the pineal gland. It's a region above the thalamus, and the important structure there is called the pineal gland. The pineal gland contains what we call the pinealocyte, which will secrete what we call melatonin. The melatonin is what regulates your sleep-wake cycle. So when they ask the evening, then you see then melatonin level what increases, then you feel what sleepy. It is known that leaching in young males may cause precocious what puberty. So that one too is something that we have found out. Now, then finally, hypothalamus. Hypothalamus is hypo means below. So that one is below the thalamus. The hypothalamus controls the autonomic nervous system, and it also controls the endocrine system. Why am I saying that? This is the hypothalamus, and this is the pituitary gland. So the hypothalamus controls the autonomic nervous system. So that point is very important. 2, the hypothalamus is responsible, regulates your hunger, taste, body temperature, your sexual drive is the work of the hypothalamus. When we studied the urinary system and the digestive system, we saw that the hypothalamus produces what? Oxytocin. Produces oxytocin and what? ADH. So you see the hypothalamus producing oxytocin and ADH. Then they are stored in the posterior lobe of the pituitary gland. So when the amount of water in the body is low, you realize the ADH will be released. The osmoreceptors in the hypothalamus will tell the posterior lobe to release the ADH. ADH will make the collecting that permeable so that there will be reabsorption of water. Then you have what? Hemostasis. Then we also know oxytocin. That one, I don't have to talk about that. Then you also know that hypothalamus also produces a lot of hormones, releasing and inhibiting hormones that will either suppress or that is either inhibit or stimulate the release of hormones from cells that you find in the anterior lobe of the pituitary gland. For example, the gonadotropin releasing hormone produced by the hypothalamus will act on the gonadotropes in the anterior lobe to secrete, you see, the gonadotropes to relieve FSH and LH. We know LH, that is, it acts on the lady cells to produce testosterone. We know LH is what's responsible for what? Ovulation. Then FSH is responsible for spermatogenesis. It's also responsible for follicular phase of the menstrual cycle. So that is how that's it. And look at here, there are nuclei. Every nuclei, there are specific nuclei that does specific what? Point. For example, the ventromedial nucleus of the hypothalamus, that is the satiety center, because we know that the hypothalamus controls your what? Your hunger. So you see, when this nucleus is damaged, then it means that you don't know that you are full, because you continue to eat and then you become what? Obese. There's this one too here. The destruction will result in what? Starvation. So there is a center here. When it destroys, you get into what? Hyperthermia. So you have these centers performing what different what rules. Okay, so that is the hypothalamus, controlling almost everything. Then we have the brainstem. So I'm done with the diencephalon. Then the brainstem is the midbrain, the pons, and the medulla oblongata. For the midbrain, what I really want you to note about the midbrain, the pons, and the medulla oblongata, the first one is that cranial nerve 3 to cranial nerve 12, they all arise from the brainstem. Cranial nerve 3 to cranial nerve 12, they all emerge from what? The brainstem. And all the cranial nerves are on the anterior aspect. The only cranial nerve that arises from the back is cranial nerve 4, the trochlear nerve. So this is a trochlear nerve arising from behind. All of them arising from at the front. So with the midbrain, it associated with cranial nerve 3 and cranial nerve 4, oculomotor nerve, and the trochlear nerve. Now, if we are to look at the function of the midbrain, then of course we can talk about the function of oculomotor nerve. We can talk about the function of the trochlear nerve. But I'm not taught you cranial nerves, so let's look at other things that you can see. On the posterior aspect, you see these 4 rounded elevation. We call them the colliculi. This is the superior colliculi. This is the inferior colliculi. The superior colliculi is responsible for visual reflex. Visual reflex. Then the inferior auditory reflex. If you want to remember, some people will say, yeah, your eye is above your ear. Your eye is above your ear. So superior one is for visual pathway. The inferior one is for the auditory pathway. So you see, something will just pass by, then you just tend to look at it. So that is what we are talking about. That's the visual and the auditory reflex that we are talking about. Okay, so that is the midbrain. Then the pons. When you studied the respiratory system, the respiratory centers are in the medulla oblongata and in the pons. The medulla oblongata and in the pons. And in the pons. The main center is the medulla oblongata. This is the pons. The pons is associated with cranial nerve 5, cranial nerve 6, cranial nerve 7, and cranial nerve 8. So, of course, if you know the function of these cranial nerves, you can also deduce the functions of the pons. But I want you to remember the pons when it comes to it being a center for what? Respiration. Then finally, we have the medulla oblongata. The medulla oblongata has associated with cranial nerve 9, 10, 11, and 12. The medulla oblongata is where your vital center is. This is where the cardiac center. So when you study the cardiovascular system, the medulla oblongata will be mentioned. Respiratory system, medulla oblongata will be mentioned. And when you study the carotid body and the what do you call it? Carotid sinus, that one will also have mentioned because that is where your pressure center is located. Then the center for coughing, sneezing, salivating, gagging, hiccuping, vomiting, all those autonomic reflexes, they are located in the medulla oblongata. Then the last important point that I want to say about the medulla oblongata, there's this area here that we call the decussation of the pyramids. There's decussation of the pyramids. Within the cerebral cortex, there are some type of neurons that we call pyramidal cells. They are pyramidal neurons. They are giant pyramidal neurons. Their cell bodies were great to form the cerebral cortex. Their axons will form what we call the corticospinal tract. So this bulging that you are seeing here, this bulging that you are seeing here, information from the cerebral cortex that is going to supply what we call voluntary movements of the limbs. They all pass here, the cortical spinal tract. The cortical spinal tract, so that's why we call this one the pyramids, because the neurons are pyramidal in shape. They cross here. They cross here. So the left corticospinal, the right corticospinal tract will cross and be on the left side. The left one to will cross. It is the reason why we say that the right hemisphere controls the left side of the body, and the left hemisphere control voluntary movements on the other side of the body. I need to add the word voluntary movement. Because the corticospinal tract, they decussate, they cross at the medulla oblongata. At the medulla oblongata. So that is the decussation of the pyramid. Okay. So remember, is the vital centers are there. Look at the cranial nerves associated with them. And I will also explain why the right side of the body controls voluntary movement on the opposite side. It's because the corticospinal tract, they cross at the medulla. Okay. Okay. So that's the medulla oblongata. So the next thing that I want us to talk about, and that will be the last thing that I'll talk about, will be the, oh, okay, you let me say this one. There is something that we call reticular formation and the reticular activating system. Within the brainstem, the midbrain, the pons, and the medulla oblongata, there is a network of nerve fibers that is spread throughout the brainstem. We call it, that's why we call it the reticular formation. Then that network, it connects to the diencephalon, to the cerebellum, and to the spinal cord. That reticular formation contains what we call the reticular activating system. What it does is that it's responsible for attention, alertness, arousal, consciousness. That is the work of the reticular activating system. So you see that when you go to sleep and someone opens the door, there is sound. Someone opens the curtains, there is light. Those one can activate the reticular activating system so that you can wake up. You can wake up. So you have here, you can wake up. So, but there is no input from olfactory receptors, like meaning smell. Smoke cannot awaken a sleeping person. So when there is a smoke, it cannot activate the reticular smell cannot awaken the cannot activate the reticular activating system. And that is why smoke detectors are installed. So that with a smoke detector, alarm will blow. Then when you are asleep, you can You can wake up. That's how come most of the time when there's fire, I see some people dying in their sleep because of the smoke doesn't activate the reticular activating system. Now, what it means is that inactivation of the reticular activation system will induce sleep. damage will lead to what? Coma. The reticular activation system also filters sensory what? Input. You see, when you even go to a market and there are so many noise, a lot of people are talking, but when you're looking for your friend and your friend talks, make a sound, you'll still be able to know. If a woman goes to a place and there are so many children, and a baby is crying, she's able to filter all the unnecessary sensory word information. So it filters and it prevents sensory overload by allowing the brain to ignore repetitive or insignificant words information. That is the work of, and it regulates your sleep and wakefulness. It means that it works with the what? Hypothalamus. So if you are attentive, that is you see that then if inactive, then you see that I'm talking there, you still be what? You still be feeling asleep. It's maintain consciousness. That's what I regulate consciousness. Without this, a person cannot remain what? Awake. So remember, in the brainstem, the midbrain, the pons, and the medulla, there is this network of fibers that we call the reticular formation, contain the reticular activating system, and that is responsible for your alertness. Okay. Now, someone should raise hand if you have a concern. Please, can you take it again? Thank you. When you say take it again, I will not know where you are saying that you should take it again. The name of the tract is the corticospinal tract. In fact, the corticospinal tract, I remember saying it. You remember when we were looking at I remember when I was talking about the external inner sphincter, the external inner sphincter, and the external urethral sphincter. I told you that they are skeletal muscle. Although they are skeletal muscles, I told you that if you are a child, you will defecate on yourself and urinate on yourself. And that's why you put on diapers. Why? Because although they are skeletal muscles and they are under your voluntary control, the myelination of the corticospinal tract is incomplete. It's incomplete. So it's corticospinal tract. We'll look at the spinal cord and everything. Corticospinal, that means it's coming from the cerebral cortex and into the spinal cord. It's the one that controls the voluntary movement. Most of the fibers will cross at the medulla. Those ones that will cross at the medulla are called the lateral corticospinal tract. Those that do not cross will be the anterior corticospinal tract. But then the main thing that I want you to know is that the crossing happens at the medulla. And because they cross, you have the left side controlling the right side of the body, the right hemisphere controlling the left side of the body. And here I'm saying voluntary movements because that one must be stated. Edwin, Anna, the coursework. I'm not going to talk about the cranial nerves, but I'll only talk about the cerebellum. Then I'll end the class. Edward, you can talk. Eddie?
Hello, sir.
Yes.
Sir, I'm really enjoying the class, but I just want to remind you that we have 15 minutes to end the class.
Yes. So I'll just do this slide and then that is all.
All right, sir.
So
Thank you very
that
much.
so the cerebellum. The cerebellum, if you are thinking about cerebellum, these are the things that you should know. One, voluntary movements, posture, balance, equilibrium. So it coordinates It coordinates voluntary movement and help to maintain balance and posture. Okay. So these are some other tasks that they will do. In fact, if you want to move a particular part of your body, now like I'm talking, moving my muscles that as I speak, the initiation is actually will come from what? The cerebrum. That one will come from the cerebrum. That one will come from the cerebrum. So imagine that your nose and you want to touch your nose. So the initiation will come from the cerebrum. That you want to touch your what? Your nose. Because if you look at the cerebrum, there is an area here, this side here, this side here, this here, and some parts here. That's the primary motor cortex. So those motor information that concern with movement, the initiation will start from there. So as I was using an example, trying to touch your nose. But then as you are bringing your index finger to your nose, some muscles must contract, some muscles can relax. Then the timing should also be precise. So that is what the cerebellum does. So you realize that when there is cerebral damage, and you want the person to touch the nose, the person will not be able to touch the nose. The person will be dodging. It cannot touch the tip of the nose. Because the coordination of the voluntary movement is what is impaired. And that's why they have unsteady gait and poor coordination. So ataxia, those people, so that's if those people that take up alcohol, you see, it affects their cerebellum. So you see, they are not able to stand well. So there's poor coordination. There's poor coordination. In fact, if you allow them to do pronation and supination, their palmar surface will be up, and their palm that is supination, palmar surface is down, that's pronation. They are not able to do that. In fact, they will do, but then it will be very, 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 very slow. So inability to perform rapid alternating movement, that is diadochokinesia. So that is that. But the one that you should not forget is this one, intention tremor. The tremor occurs during voluntary movement. So there's intention tremor, and there is resting tremor. Intention tremor will diagnose cerebral problem, but resting tremor will diagnose Parkinson disease. So in an intention tremor, it means that, as I said, trying to touch the nose. So is a person, there is an intention, but then the hand will be shaking, and that's why the person will not be able to touch the nose. So that is the intention tremor. Then in Parkinson disease, you see, even when the person is not doing any movements, the hand is resting, but the hand will be shaking. That one is what they call the resting tremor. That one is a sign of Parkinson disease. The intention tremor is cerebral problem. Most of these things, when you are actually seeing how to detect it, that one's better than the way I'm saying it. The another thing is that cerebral fibers are ipsilateral. That means they are on the same side of the body. You remember, there's a left cerebral hemisphere and there's a right cerebral hemisphere. If there's a lesion on the left cerebral hemisphere, it will affect the left side of the body. If there's a lesion on the right cerebral hemisphere, it will affect the right side of the body. That's what we mean by ipsilateral. It's ipsilateral. It's not like the left one controls the right and the right one controls what? The left. So you know that when it comes to the ear, one of the functions of the ear is not hearing, but also balancing and what posture. So you see, even when your eyes are closed, Krana, you can balance your body. So however you are positioning your body, the cerebellum is the one doing that for you. So if your head is upside down, is your cerebellum, even when your eyes is closed, it's the cerebellum that will relay the information to you. So the cerebellum coordinates the timing, precision, and smoothness of voluntary movement. It also helps to maintain posture, balance, and equilibrium. So nystagmus is another sign of what? Cerebellar damage. This one, Ubun said that the eye will be shaking like that. Okay. So that is that. So your quiz will open at 6:30, then it will close at 8:30 in the morning. Please, some people, in fact, some have even something happened and one or two people did it or something like that, and they had everything correct. So here you're going to get 100. So it's 1 hour, 80 questions. 80 questions. Please, when you finish at 8:30, I will check. If there's any problem, I'll communicate with the coursework. But because I've given you a very long duration, don't be in a rush to do it. Just make sure that your internet is okay before you start. Before you start. You all of you have only one attempt. You only have one attempt. Only have one attempt. The questions, 3 questions will appear at a time. 3 questions appear at a time. Then you can, it's not as if you can do any question anytime. So that is that. Thank you very much. Next week, was it areas? The areas in areas, so what we've done so far. So with the beginning of the second semester, we talk about the urinary system, we talk about the digestive system, then the male and female reproductive system. So the questions are on those areas. And the questions are the ATTA, yes, ATTA in the sense that midterms, it's okay for a midterm to be 1 hour. And according to the school, 40 seconds per question. So if you do 40 seconds per question, then I think it's 80 questions is okay. In fact, some of them you use 10 seconds. Some of them you use 15 seconds. I'm not sure there will be any question that you use more than 45. You say that I'm kidding, but you go and do it and you see that the time will be more than enough for you. The time that you use, each of you will use to do the test. I'll see all those ones. Okay. Oh, yeah, yes, I made it free. So it's not as if that like question 1 comes, then I'm not sure correct, then you go to question 2. I'm not sure you can go back. You can go back. But if you submit, you click submit in ADR, then that is when I get to see the answers. So you see, that is why this one, so this one is like the way it has been done. We as some kind of free thing that I'm doing. Some kind of free thing that I'm doing. Yes, because I know those people who try and cheat the system. So this one there, it just be some kind of a So that's why even the time should even be shorter. The time should be shorter so that you wouldn't have the time to cheat the system. Okay, so thank you very much. There are no diagrams. I couldn't get a time to do diagrams, but then you I think your exams, I think it will be 3 hours. You use 2 hours to do 150 MCQs. Then use the 1 hour to do the practicals. All the structures that we have done. So if it's the heart, if it's the brain, for example, you can have something like this. Usually it's always good. I can give you something like this. Oh, there's a medulla, there's a pons, there's a midbrain, there's a pituitary gland, there's a corpus callosum, there's a cerebellum, there's a foreventricle. I can do that, or it can be something like this, where you identify. But I'm not going to let you identify something like here, mammary body, so this one, they are calling a corporal quadrigemina. This is a midbrain, this is the superior colliculus, this is the inferior colliculus. So the 4-rounded bodies formerly was called corporal quadrigemina. So this is the superior colliculus, this is the inferior colliculus, this is a pineal gland. Now, if you look at this view, you see that it is exactly what you are seeing over here. This is a pineal gland. These are the superior colliculi. This is the inferior colliculi. Okay. So it will be basic information. It's not going to be difficult. That one there, I can assure you. It's a basic information diagram that will ask you to identify. Okay. So thank you. And slide for female reproductive system. Hey, sis, share. I say I should bring the penis and leave the brain. Oh, the brain you do. In fact, the brain too, I'll try and get some. You see what? There are a lot to cover in the brain. It's very broad. So what I'll do is that I'll try and get some kind of basic questions for you as a kind of trial. So I can get questions, let's say, on the meninges, question on the ventricles, those things for you. So at least you get to know the basic things that I want you to know, and that you can be examined on. That you can be examined on. Yes. Okay, so thank you very much, and have a wonderful message. Bye-bye.